Hello everyone, this lecture is on the theories, models, and frameworks that are used in health education. And while these are all the slides that are in Blackboard, the slides will be divided into 4 separate lectures so they're shorter and easier to watch. So these are questions you need to ask yourself when you are selecting a model. The first one is, which model, theory, or framework is most appropriate for your population or for your program? That should always be a consideration. Sometimes your stakeholders, the people who you're working with or who are receiving the program, sometimes they have a preference as to what model you use. And if the people for whom you're developing the program say we want you to use the theory of reasoned action, then that's the one you use. You also have to look at how much time you have available and how many resources you have available. And I'm putting them together because time is an actual type of resource. So if you wanted to use a model that takes 7 years and you don't have 7 years, then that's probably not the best model. If you have a model that needs you to spend $10,000 and you need 10 people to implement it, and you have $1,000 in one person, then that's not the model that you can use. So those are really very important issues to consider when selecting a model. Then you have to decide how much of input do your clients or customers have. Are they truly partners, or are they truly customers or clients, or are they a combination of both? That too can influence what you decide. Sometimes the funding agency for your program will dictate that. Those in 315 know that the granting agencies often dictate what theory or model you have to use. And finally, and often most importantly at this point in your career, you need to consider how comfortable you are with a model and how knowledgeable you are with a model. If you choose a model that you do not fully understand, then it's not really going to be very helpful to you in planning your program. So these are the models that we're going to talk about in all 4 of the lectures. Precede, proceed, health belief model, Aschen-Fishbein's theory of reasoned action, social cognitive or learning theories, trans-theoretical model of change, theory of organizational change, diffusion theory, theory of problem behavior, and the social ecological model. These are not all the models that can be used in health education, but these are often the ones that are used the most often. So here is the actual outline of what precede proceed model looks like. If you ever see this, you should automatically know that this is the precede proceed model. Some really important facts. It looks like we start at the top right and work our way all the way around and then down the bottom because things are numbered 1 to 9. In reality, when you're working across the top, you're working across the bottom at a similar time frame. So when you're working on phases 1 and 2, you'll be considering phase 9. When you work on phase 3 and 4, you'll be working on phase 7 and 8 at the same time. So let's talk about this. Phase 1 is the social assessment, and that is really the quality of life. And quality of life is determined by things like the rate of poverty, housing, educational attainment, what are the health data in that area, how healthy is the population. Those are all the big picture items. That's the quality of life. Phase 2 is the epidemiological assessment, and that's when you're looking at the health data, typically national data, and you're looking at incidence, prevalence, morbidity, and mortality. Remember, incidence is new cases, prevalence is total cases, morbidity is illness, and mortality is death. Those 2 items, phase 1 and 2, will actually make up your outcome evaluation, and we'll talk about that. Phase 3 in the precede proceed model is the behavioral and environmental assessment, and this is where all health behaviors typically fall into one of these 2 categories. Either they are based on the individual behavior and lifestyle, or they are within the environment. So if someone eats a lot of junk food, that would be individual behavior. But if they live in a food desert, that would be how the environment contributes to that behavior. So for every issue in health, there are both individual behavior and lifestyle components and environmental components. And in reality, you have to address both if you want to address the quality of life. Phase 4 is the educational and ecological assessment, and these are the ones that are most often used as you're starting, and that is to look at predisposing factors, reinforcing factors, and enabling factors. Predisposing factors are those items that your population has when they come to you. Are they obese? Are they educated? What is their age? What is their race? What is their sex and gender? Those are predisposing factors. That's what they come with. Then you have reinforcing factors, and those are the factors in the environment or community or culture that reinforce either the unhealthy behavior or the healthy behavior. So if someone is obese, a reinforcing factor could be that everyone in their family is obese. It could be that in their ethnicity, they eat high-fat foods. It could be that nobody thinks proper weight is important or healthy weight is important. Those are all reinforcing factors. And finally, enabling factors consist of 2 items. They consist of accessibility and availability. So, for example, if we go back to the food desert issue, if a grocery store is within 2 miles of someone's home, that sounds available. However, if they have to take 2 buses to get there, and it takes an hour to get there and an hour to get back, and they have 3 children under the age of 6, and they have to take their children with them when they go, that is not really accessible. When you look at health services and treatments and preventions and interventions, availability and accessibility are very important. So someone could have a contraceptive clinic on the corner of their street, and that means it's available. But if the hours are only open when they're at work or at school, it's not accessible. If they don't have the money or the insurance to pay for the service, it's not accessible. So all 3 of these items need to be considered when you're planning a program using Precede Proceed. Next, in phase 5, we have the health education program and policy regulation. And as you're working through models, sometimes policies dictate what you can and cannot do, and you have to stay within those policies. So then you have your implementation phase, and then across the bottom we have the 3 types of evaluation, and then I'll talk about how they relate to the top. So process evaluation, those are the evaluations that you put into place to evaluate the processes. So you're doing a program at 2 different churches. One church has 100% participation. The other church has 25% participation. There's something wrong. So the process evaluation would be to stop and look at, well, what processes are in place that are not working for us? Another example of process evaluation is that you're having meetings and you're keeping minutes for your meetings, but tasks are not getting accomplished. Something's wrong. So you could just continue doing the same thing over and over and getting the same results, but in process evaluation, you would stop and say, what's wrong with our process? Why aren't we getting the results we need to get? And that's a very important aspect, because it does not make sense to continue to do things a certain way if they're not working. The second phase, phase 8, is impact evaluation. And these words are unique to Larry Green. There are different, using different models, these terms mean different things. So in this model, impact evaluation is what happens immediately following your program. So you have a health fair, what's the impact? What happened right afterwards? You run a dietary course. What's the outcome? What's the impact, excuse me? What happens right after your program? So here you have process, and in the process you can see we're looking at right before you implement the program and during implementation. That's what you're looking at. In impact evaluation, you're looking at it when you're working on phase 4 and phase 3. What you're doing here will affect impact. Did you change behavior and lifestyle? Did you change environmental issues? Did you address predisposing, reinforcing, or enabling factors? So that's how this impact evaluation relates to these two phases across the top. Next, phase 9 is outcome evaluation, and outcome is long-term. And if you look at the top, we're looking at quality of life and epidemiological data, and that is long-term data. So if you are having a session on heart disease, you probably are going to see impact, but you're not going to see outcome after one event. Outcome typically takes 7 to 10 years for us to see big data changes across like the country or the world. So that's important because the way you look at outcome data would be very different. In most cases, you are going to be doing process and impact evaluation. You're not going to do outcome evaluation in the class. So let's look at this precede, proceed, what it does for you in particular. We looked at everything about it, but the 3 components that you're going to look at, predisposing factors, reinforcing, enabling factors, that's what's most important for us in this model. And why you would use it is if you're trying to change behaviors, or you're trying to change environmental conditions, or you're trying to address people who affect behaviors. So those are the reasons why you would use precede, proceed. This model on the screen right now is the health belief model. And the health belief model, I feel for most people, is more difficult to grasp than the precede, proceed model. However, both of these are used often in health education. So when you look at this, what's really important in the center, those are components that have to be addressed. On the left side, you have demographics, which is a lot like the predisposing and reinforcing factors in the precede model. Who's your population? Are they overweight? Are they healthy? Do they have heart disease? Do they have diabetes? What's their age? What's their race and ethnicity? What's the sex, gender? Those demographics all have to be considered when you're addressing the items in the middle. So what's most important about the health belief model is you need to be concerned about your population's beliefs, your population's perceptions, not yours. And that's often hard for people to gather information and really grasp that. So perceived susceptibility means, does your population believe they're susceptible to this issue or disease? Does your population think they are at risk for diabetes? Does your population think they are at risk for teen pregnancy? Does your population think they are at risk for stroke? Do they think they are at risk for obesity? That is a really important question, because if your population believes they are at risk, then your program will look very different than if they think they're not at risk. If you're working with a population who has high risk for diabetes and they do not believe they are susceptible, then you have to address that perception in order to move forward. The next item in the health belief model is perceived severity, and that requires you to ask the question, does your population think that this condition is severe? Is it serious? So I'm going to ask the same kind of questions. If you're working with teens, do they think that there are serious consequences of teen pregnancy? So 1, do they think they can get pregnant or have babies? And 2, is that severe? There are ethnicities and cultures where having babies at a young age is not considered bad. So if you're dealing with that population, you need to understand that perception. Does your population think that diabetes is severe? Do they understand that when someone has diabetes, they are more likely to have heart disease, more likely to have stroke, more likely to have issues with blood circulation and possible amputations? Do they understand how serious this is? Do people understand how serious it is to be obese? So this question is asking you to think about your population. Do they think it's severe? The next one is the perceived benefits. And perceived benefits means the benefits of the behavior. So, what are their perceptions of the unhealthy behavior and what are their perceptions of the healthy behavior? What's the benefit of them maintaining unhealthy behaviors? What's the benefit of them maintaining healthy behaviors? For example, if someone enjoys being with their friends and their friends all get high, the benefit to them, their perceived benefit, is acceptance of their friends and being social. For some groups of people, that's very important. That's more important benefit than saying to it for teenagers, for example. Teenagers want to fit in, they want to belong, they want people to like them. That, for most teens, is more important than you saying to them, you could die from that. You could have heart disease 20, 30, 40 years from now. If you smoke, you're going to get lung cancer. When you look at the benefits, you have to look at what the people think are benefits. You then have to use those benefits to your advantage to get people to alter their behaviors. The next one is perceived barriers, and this is your population's perception of barriers. Does your population think there are barriers to them performing the healthy behavior? So if you want them to exercise, do they believe there are safe places to exercise? Do they believe they can get to those safe places to exercise? If you want them to maintain healthy weight, not only are we talking about exercise, but are there healthy foods available? Can they get to the healthy foods? Can they afford the healthy foods? What's more convenient, healthy or unhealthy? If you want someone to get STD testing routinely, is there a barrier? Can they get to the STD testing facility? Is it open at convenient hours? Are they embarrassed to go there? So all of these concepts, they're barriers to your population. It doesn't matter if you think they're barriers. It matters what your population thinks. And finally, self-efficacy. In self-efficacy, this is when people believe they can do what you want them to do. So I'm going to give you a couple examples of self-efficacy. When AIDS first came out, there were no such thing as female condoms. There were only male condoms. So in working with prostitutes, we were trying to teach them how to negotiate having their partner wear a condom. Well, that was clear to us very early that they did not believe they could negotiate that most men were not going to want to wear a condom, so why even ask and then possibly get beat up or lose your John? So instead, what was taught was how it was called cheeking. And cheeking, like your cheek in your face, cheeking is when the woman put the condom in her cheek and during oral sex on a man, she put the condom on his penis without him knowing it. And so they all believed they could do that. And so that's what we worked on. So something we thought was so easy, well, you're just going to negotiate it. That was not easy for them. That they did not believe they could do that. So you have to figure out what your audience thinks that they can do. If you want people to maintain healthier weight and they don't believe that they can do it, they don't believe they can make good tasting food, and they don't believe their family will eat it, and they don't believe their parents will buy the healthy food, then they're not going to do what you want them to do. If you want people to quit smoking or quit using drugs, you have to have them believe that they can do what you're asking them to do. No one likes to fail, and people especially don't want to feel bad about failing and trying to do healthier behaviors. So that's very important. Across the bottom, you have the cues to action. That would be things like your program. And then to the right, we have behavior change. So if you consider people's demographics and you consider these perceptions and you develop a program that addresses all of this, it should lead to healthier behavior. And that's very important when you're dealing with health education. So the health belief model, what's really critical is if you need to deal with the perceptions that affect behavior, if you're trying to look at individuals' perceptions and trying to address perceptions in order to change health behavior, this is a very good model to use. And the third model, what you see on the screen, is the theory of reasoned action by Fishbein and Aschen. And so there are a couple important items to consider in this. The first one I'm going to talk about is at the end of the model, behavioral intention, and behavior. So behavioral intention leads to behavior. That's been proven statistically in many studies. If I tell you I plan to wear my seatbelt, I'm probably going to wear my seatbelt. If I tell you I plan to use condoms, I'm more likely to use condoms. If I tell you I plan to eat 5 fruits and vegetables every day, then I'm more likely to eat 5 fruits and vegetables every day. So the concept between the theory of reasoned action is sometimes there's behaviors that we cannot observe. So for example, if you want people to use condoms every time they have sex, you should not be watching that behavior. That would be inappropriate. Instead, you could ask them an intention question. Do you plan to use condoms every time you have sex in the next 3 months? If you want people to visit the doctor regularly, do you plan to visit a doctor or healthcare provider in the next year? Do you plan to do breast self-exams or testicular self-exams every month for the next 6 months? You can't see those behaviors. And in some cases, you should not see those behaviors. So when you cannot measure the actual behavior, the next best thing is to measure behavioral intention. The next thing in looking at this theory of reasoned action is across the top and across the bottom. So beliefs and attitudes affect behavior. And you've heard me say this before, and you should have heard other professors tell you before, that behavior is very much based on beliefs and attitudes more than it is knowledge. So in this model, you really have to address their beliefs and attitudes like in the health belief model. Along the bottom part of the model, there's something new here. And what's new at this point is the concept of normative and subjective beliefs or norms. So if all your friends get high, you're more likely to get high. If you live in a neighborhood where everyone gets high, you're more likely to get high. If, for example, right now in our country, there are lots of racist comments and beliefs that are said out loud, if your country is set up in a way that those are acceptable comments, then they will be said. If you're in a situation where it's unacceptable to make derogatory statements about people's ability levels, their race, their sex, their gender, their orientation, then it is less likely to be said. So you have what does the culture or society say is okay, and then what do your close friends say are okay. So you need to address those issues. If you're developing a program, sometimes you need to stop and say, well, and I'll give you a very simple example, and that is ethnicity and food. So if you're working with an ethnic group that uses high-fat cooking techniques, and you want them to change their diet, you must address the norms of that culture, that community, that neighborhood. And then, for example, you might address, well, how do you still make those foods tasty but do it in a healthier way? You would fail if you went in and said to an ethnic group, let's get rid of all your ethnic food and let's just eat like this. That would be an ultimate failure. But if you went in and said, wow, these foods that you make are really delicious, they're some of my favorite foods, I'd like to teach you how to make them, but make them a healthier way, but they still taste good, now people are willing to listen to you. So these are the premises of the theory of reasoned action. One is behaviors and attitudes really are very good indicators of behavior. An intention to perform a behavior is a very good indicator of behavior. And what the overall cultural norms are, and then the smaller community ethnic group norms or beliefs, those two are important at projecting behaviors. So the reason why you would use the theory of reasoned action is that you want to know how behavioral intentions relate to behavior, or you're trying to measure a behavior and you cannot actually measure the actual behavior. So you would be planning a program to address beliefs, cultural, and societal norms, and then you would possibly measure intention and not behavior. So that ends the beginning slide presentation. We're going to stop after those 3 presentations. Feel free to take a break and then come back and watch the other 3 slides.